Good evening, ladies and gentlemen. Topic of today's lecture is inherited metabolic diseases. This topic has always been a difficult topic for me during my undergraduate days. The reason again is because of the diverse nature of diseases which are covered in this topic, the diverse nature of the dermatological findings, and too much text which is written in the textbook. So I have tried to make this topic easy to understand, but with all the details, it will again be a little lengthy lecture. So let's proceed to the lecture. The inherited metabolic diseases or the inborn errors of metabolism are caused by deficiencies of enzymes or transport proteins. Since the metabolism in the body is governed or is run by different enzymes and transport proteins, so definitely when we are dealing with some inborn error of metabolism, we are dealing with some deficiencies of enzymes or the transport proteins. They are extremely diverse and often affect several different systems of the body. The classification is based generally on the organelle or the pathways involved. So in this lecture, we are going to discuss the inherited metabolic diseases under the following 6 main headings. The first will be the lysosomal storage disorders. Then there will be mitochondrial respiratory chain disorders. Then there will be congenital disorders of glycosylation. Then there will be the disorders of amino acid metabolism and transport. Then disorders of cholesterol synthesis. Then some miscellaneous metabolic disorders. Among these 6 disorders, there will be 3 disorders which are of importance as far as the diseases which will be discussed under these headings. The important metabolic disorders are highlighted in red. So, first of all, the first metabolic disorders we are going to discuss are the lysosomal storage disorders. The lysosomal storage disorders means deficiency of one or more hydrolases that leads to accumulation of various molecules in the lysosomes. These are progressive, multi-system diseases, but the clinical features vary depending upon the precise disorder and severity of the enzyme deficiency. The characteristic dermatological findings are angiokeratomas, which are most commonly seen in the Feberish disease, but are also seen in many other lysosomal storage disorders, and thickened skin and hypertrichosis. So these are the 3 major dermatological findings in the lysosomal storage disorders that include angiokeratomas, thick skin, and hypertrichosis. Most of the patients have coarse facial appearance when combined with abnormalities of facial skeleton as seen in Muco Polysaccharidosis. So in addition to the 3 main dermatological findings, coarse facial features is also a common appearance. Among the lysosomal storage diseases, the first of the diseases which we are going to cover are the Muco Polysaccharidosis. Muco Polysaccharidosis are a family of inherited multi-system disorders caused by defect in the degradation of glycosaminoglycans, which accumulate within the lysosomes. So the defect in the enzymes and defect are in those enzymes that are responsible for degradation of glycosaminoglycans result in their accumulation within the lysosomes. Dermatan sulfate, heparin sulfate, and keratin sulfate are the main glycosaminoglycans that accumulate in mucopolysaccharidosis disorders. So these are the three glycosaminoglycans that are stored in mucopolysaccharidosis: the dermatan sulfate, the heparin sulfate, and the keratin sulfate. All mucopolysaccharidosis are inherited as autosomal recessive traits, except for mucopolysaccharidosis 2, which is also known as the Hunter syndrome, which is X-linked. Clinical features include the coarse facial appearance, hepatosplenomegaly, bone dysplasias, and developmental regressions. Mucopolysaccharidosis are classified from 1 to 9. Mucopolysaccharidosis 1 comprises of Hurler syndrome, which is severe, Hurler-Shai syndrome, which is intermediate severity, and Shai syndrome, which is of mild nature. Then mucopolysaccharidosis type 2 is the Hunter syndrome. Mucopolysaccharidosis type 3 is the Sanfilippo syndrome that results from deficiency of 4 different enzymes. Then mucopolysaccharidosis 4 is the Morquio syndrome with deficiency of 2 different enzymes. 5 is not there, and then mucopolysaccharidosis 6 is the Martu-Lemmy syndrome. Then 7 is the Sly syndrome, 8 is not listed, and 9 is the Notwish syndrome. Clinical features. The mucopolysaccharidosis present in early childhood with developmental delay, deafness, and upper respiratory problems. A few patients present with skeletal and cardiac problems. These patients have coarse facial appearance as seen in the picture. There is hypoplasia of mid-facial bones lead to flat nasal bridge. The skin is thickened, as are the lips, and tongue is enlarged. So there is macroglossia. Many patients have hypertrichosis and fusion of the eyebrows. Hands appear chubby with short and broad digits. Corneal clouding is seen in mucopolysaccharidosis 1, 6, and 7. This is the corneal clouding. Then ivory white papules or nodules are often seen on back of patient with severe mucopolysaccharidosis type 2, that is Hunter syndrome. Individual nodules range from these are the nodules, 1 to 10 millimeter in size and coalesce to form ridges or reticular pattern. Papules may be found on the upper arm and outer thighs. Mongolian blue spots are common in Hurler and Hunter syndrome. In addition to the sacrococcygeal region, they are found in upper back and anterior trunk or the limbs. This is Mongolian spot which is seen in this picture. So they are, in addition to the usual area of sacrococcygeal region, these spots may be seen on upper back, anterior trunk, and on the limbs. There is a developmental regression is a dominant feature of mucopolysaccharidosis type 3. Behavioral problems, sleep disturbance, and gradual deterioration into a vegetative state occur. There are learning difficulties in Hurler syndrome and in severe cases in type 2 and type 7. Other neurological problems are seizures, hydrocephalus, spinal cord compression, and carpal tunnel syndrome. The most important of the systemic feature is the bone dysplasia, which is also known as the dystocia multiplex, dystosis multiplex. These are the patients have a very short stature. They have a joint laxity, arthritis of hip and knee, and risk of atlantoaxial dislocation. Other joints are stiff and short, and they are associated with kyphosis. There is ear, nose, and throat infections and upper respiratory airway obstruction and deafness. Valvular heart disease is often the cause of death in such patients. Differential diagnosis of mucopolysaccharidosis include other lysosomal disorders like glycoprotein breakdown disorders, mucolipidosis, and few sphingolipidosis. Investigation. In all mucopolysaccharidosis, urine for glycosaminoglycans is a preferred investigation, which is done preferably by two-dimensional electrophoresis. Mutation analysis is also possible. If we take a biopsy, the epidermis is distended with pale cytoplasm, the keratinocytes, and fragmentation of collagen with increased tissue mucin is seen. So first is the epidermis, which is light colored because of pale cytoplasm, and secondly, there is disrupted collagen, and the collagen is interspersed with lots of mucin. Management. Symptomatic treatment is important. Medications are useful for sleep and behavioral problems. Hematopoietic stem cell transplantation is established treatment for Hurler and Martu-Lemay syndrome. Transplantation in infancy leads to improvement in most systems. Enzyme replacement therapy is now available for mucopolysaccharidosis 1, 2, 4, and 6. Its major limitation is the inability of enzyme to cross the blood-brain barrier, and hence limitation in effect in neurological side effects. Bone and heart valve disease is also resistant to replacement therapy, although outcomes can be improved if the treatment is started earlier. The second category of disorders we are going to discuss under the main heading of lysosomal storage disorders is the glycoprotein degradation disorders. Most secreted and cell surface protein are glycosylated. Deficiency of an enzyme leads to storage of various oligosaccharides and or glycopeptides depending upon the precise defect. The disorders are all very rare and inherited as autosomal recessive traits. Some of the disorders resemble mucopolysaccharidosis with similar facial appearance and skeletal dysplasias. And angiokeratomas may occur in some disorders. Angiokeratomas are not a feature of mucopolysaccharidosis, but may be seen in these glycoprotein degradation disorders. So investigation, abnormal oligosaccharides can be detected in urine by thin layer chromatography. Enzyme assays are crucial in establishing the diagnosis, and most of the enzyme assays can be performed on leukocytes. Management. For most, only symptomatic treatment is available. Enzyme replacement therapy is being developed for alpha-mannosidosis. Bone marrow transplantation may improve the neurological outcome in fucosidosis. Details of individual disorders are now given. Fucosidosis. Fucosidosis present in childhood with developmental delay followed by neurological deterioration. Other clinical features include mild mucopolysaccharidosis like facial appearance, short stature, hypohidrosis, and hepatosplenomegaly. Angiokeratomas appear in mid to late childhood and are confined to the limbs. Similar lesions may occur on lips, gums, and tongue. Alpha melanocytosis. They are associated again with mucopolysaccharidosis type facial appearance, with learning difficulties, deafness, corneal clouding, cataract, dystosis multiplex, hepatosplenomegaly, and frequent infections. Beta melanocytosis present with learning difficulties, deafness, frequent infections. Face is not coarse, but angiokeratomas are occasionally present. Sialidosis occur with two main types. The mildly affected type 1 present in adolescents or adults with myoclonus, visual impairment, and macular cherry red spots on fundoscopy. Sialidosis type 2 present in early childhood with mucopolysaccharidosis-like appearance, developmental delay, dystosis multiplex, and hepatosplenomegaly. Then there are aspartyl glycosaminogurias. Patients have developmental delay and gradually become severely retarded. There are coarse features, sagging of the skin, thick lips, broad, low nasal bridge, and coarse hair. Facial angiofibromas are important, and gingival overgrowth and edema of buccal mucosa occur. Alpha and acetyl glycosaminodase deficiency, extremely rare and reported in infant with neurodegeneration. The angiokeratomas may have similar distribution as Fabry disease, or there may be more widespread. So all these disorders, which are discussed under the heading of glycoprotein degradation disorders, are rare. They are autosomal recessive, and they have mainly the features of neurodegeneration, developmental defects, learning difficulties, and have coarse facial appearance like mucopolysaccharidosis, dystosis multiplex, and angiokeratomas. Then the third metabolic disorders we are going to discuss under the lysosomal storage diseases are the mucolipidosis type 2 and type 3. Mucolipidosis are autosomal recessive disorder, as most of the metabolic diseases are, in which the multiple lysosomal enzymes fail to enter their organelles. Mucolipidosis 2 or 1, which is cell disease, referred to severe end of the spectrum. Patient present as birth with coarse facial features, gum hypertrophy, neurological involvement, dystosis multiplex, and cardiomyopathy. In mucolipidosis 3, main problem is arthritis due to skeletal dysplasia and mild learning difficulties. Diagnosed by demonstrating raised level of mistargeted lysosomal enzymes, and only symptomatic treatment is available. Then the fourth disorder we are going to discuss under the lysosomal storage disorders are the sphingolipidosis. Sphingolipidosis are important metabolic disorders which we are going to discuss, and they are important as far as their as we expect them asking in the exam. Sphingolipids are the amphiphilic molecules found in cell membranes. Amphiphilic molecules are those molecules which are at one time are hygroscopic and hydrophilic. They are degraded by lysosomal hydrolases, and deficiency of these enzymes cause accumulation of sphingolipids called as the sphingolipidosis. In some sphingolipidosis like Tay-Sachs disease, problems are confined only to the nervous system, while other sphingolipidoses are associated with mucopolysaccharidosis like facial appearance, angiokeratomas, and other dermatological abnormalities. All are autosomal recessive except the important and common Febrile disease, which is X-linked. Among the sphingolipidoses, the first is the Gm1 Gangliocytosis. Rare presentation in neonate with hydrops fetalis, hypotonia, hepatomegaly, and facial dysmorphism. Neurodegeneration is the main feature, comprising of dysarthria, dystonia, and skeletal dysplasias. Angiokeratomas are prominent. Angiokeratoma is a prominent feature of all the sphingolipid disorders. Then galactosialidosis, extremely rare, and it is a combined deficiency of neuroaminidase and beta-galactosidase. Neonatal onset resembles Gm1 gangliocytosis. Later onset looks like mild mucopolysaccharidosis like facial features with neurodegeneration and angiokeratomas. Then Gaucher's disease. The Gaucher's disease is the most prevalent lysosomal disorder, and there are three clinical types. Type 1 is non-neuropathic, type 2 is acute neuropathic, and type 3 is subacute neuropathic. So in type 1, which is also the commonest of the Gaucher's disease, present in children or adults with hepatomegaly, splenomegaly, with thrombocytopenia because of splenomegaly, and by ischemic bone crisis. The cutaneous features are diffuse yellow-brown pigmentation, easy tanning, telangiectasias, petechiae, and ecchymosis. Type 2, which is acute neuropathic, present by 6 months with neurological problems that include squint, dysphagia, and opisthotonus. There will be poor weight gain. Most die by 2 years. They have congenital ichthysis that gives an appearance of collodion baby. Type 3, which is subacute neuropathic, present later in younger childhood with hepatosplenomegaly, followed by eye movement disorder and other neurological problems. They are less aggressive and less fatal as compared to the type 2 disease. Niemann-Pick disease. It is due to sphingomyelinase deficiency and classified into type A, which is neuropathic, and type B, which is non-neuropathic. So type A present in early infancy with diarrhea, vomiting, hepatosplenomegaly, and neurological problems, but patient die by 3 years of age. Type B, which is non-neuropathic, present as children with hepatosplenomegaly, interstitial lung disease, poor growth, hyperlipidemia, and thrombocytopenia. Skin may be involved in both type A and B with waxy induration and brown-yellow pigmentation, as we see in the Gaucher's disease. Mongolian blue spots are seen in children, as we see in mucopolysaccharidosis. Histology will show foamy macrophages. Then Farber disease. Farber disease is an extremely rare disease. Patient present in early infancy with hoarse cry, painful swollen joints, which may be hands, elbow, knees, and ankle, subcutaneous nodules, psychomotor retardation, and die in early childhood from respiratory infections. Histology reveals granulomas containing large foamy histiocytes, and electron microscopy show curvilinear inclusions, which are called as the Farber bodies. Investigation. Diagnosis is established by enzyme assay on leukocytes or cultured cell. Management. Management of the sphingolipidosis is the enzyme replacement therapy that is available for Fabry disease and Gaucher's type 1, but is expensive and requires slow intravenous infusion at least every 2 weeks. Enzyme replacement therapy relieves the systemic complication, but hematopoietic stem cell transplantation should be considered if there is neurological deterioration. Miglustat is an oral drug that decreases the accumulation of glucocerebrosides. In UK, it is licensed in Niemann-Pick disease, type C, and patient with Gaucher's disease type 1. Diarrhea and weight loss is common side effect of miglustat. Then comes the Feverish disease, which comes under the sphingolipidosis and is an important disease. It's also named as the Anderson's Feverish disease. The previous one was the Farber disease. Now it is the Feverish disease. So the Feverish disease is a rare X-linked lysosomal storage disorder that is characterized by angiokeratomas and multi-system complication. It is not labeled as X-linked dominant or recessive because both type can occur in this disorder. So it is just labeled as X-linked disorder. As we see in X-linked disorders, affected males are more in number and they suffer from severer disease as compared to female. The affected males present in childhood with episodes of pain in the extremities and angiokeratomas. The complications include renal failure, cardiac and cerebrovascular disease. Many heterozygous female also develop symptoms with late onset. The deficiency of alpha-galactosidose A as a result of globotriaosol ceramide GB3 that accumulate in the vascular endothelium, perithelial, and smooth muscle that leads to aneurysmal dilatation of blood vessels with ischemia and infarction. Clinical features. The first symptom of the disease are episodes of severe burning pain in palms and soles, which are the acroparesthesias, with mean age of onset of around 15 years. Painful crises are often triggered by fever or exertion and last for many hours or days. Then the second prominent feature of Fabry disease is angiokeratoma corporis diffusum that occur in 65 to 70% of male and 35 to 40% of female. They are clustered, numerous or sparse. Common sites are periumbilical, inner thigh, lower back, buttock, penis, and scrotum. The telangiectasias occur on lips, buccal mucosa, ears, or conjunctiva. Anhidrosis or hypohidrosis as a result of autonomic neuropathy. Vasomotor disturbances cause flushing, cyanosis, or blanching of the hands. Lymphedema is common and may be because of lymphatic microangiopathy. Men with cardiac variant present after 40 with cardiomyopathy. So the main feature of Fabry disease is the acroparesthesias, angiokeratoma corporis diffusum, and the vasomotor disturbances characterized by flushing, cyanosis, and blanching of hands. Differential diagnosis of angiokeratomas include purpura and angioma serpiginosum. Localized type of angiokeratomas are called as angiokeratoma circumscriptum, the scrotal angiokeratoma, which are called as the Prolidase type, and Mibili type of angiokeratomas. Then DD of angiokeratoma corporis diffusum include the Feverish disease, fucosidosis, Kansky, galactosialidosis, Gm1 Gangliocytosis, aspartyl glycosaminoglycinuria, and beta monocytosis. All of them are mainly the lysosomal storage disease disorder. The complications and comorbidities of Feverish disease are the cardiac involvement, which occur in almost all and include left ventricular dilatation and hypertrophy, mitral valve regurgitation, arrhythmias, and ischemic heart disease. Most men have proteinuria, hypertension, deteriorating renal functions. Without enzyme replacement, end-stage failure is reached between 40 to 50 years. Cerebrovascular disease leads to early stroke and transient ischemic attacks. Then vertigo, dizziness, and hearing loss are common. Other complications include abdominal pain, diarrhea, achalasia of esophagus, and arthritis of fingers. Median survival is 50 years in male patients. Investigations. Diagnosis of Feverish disease is established by skin histology or slit lamp examination of the cornea. In male, the diagnosis should be confirmed by demonstrating alpha-galactosidase A deficiency. In women, diagnosis is confirmed by molecular analysis because enzyme activity is often normal. So this is the histopathological appearance in Feverish disease. That is angiokeratoma corpus diffusum show hyperkeratosis and dilated blood vessel in the papillodermis. On electron microscopy, cytoplasmic inclusions, these are the inclusion bodies, are seen in the endothelial cells. Slit lamp examination is an important investigation to order or examination to order in patients with Feverish disease. Most adult patients have an asymptomatic corneal dystrophy that is called as the cornea verticillata. Other findings include lens opacities and tortuosity of conjunctival and retinal vessels. There are other causes of cornea verticillata, which include the pharmacological causes, as we can see this condition with chloroquine, amiodarone, indomethacin, and phenothiazine uses. The non-pharmacological causes of cornea verticillata include multiple myelomas, neurotropic keratitis, Lesch corneal dystrophy, and epidemic keratoconjunctivitis. So cornea verticillata is an important eye finding in patients of Feverish disease. Management. The acroparesthesias respond to carbamazepine, gabapentin, or phenytoin or opiates. Angiokeratomas can be removed by laser for cosmetic or other reasons. Cardiac complications are usually managed conservatively. Aspirin reduces risk of stroke, and ACE inhibitor should be started if proteinuria sets in. Renal failure is treated with dialysis or transplantation, and it is beneficial as glycolipids do not accumulate in the grafted kidney. Enzyme replacement therapy reduces the neurogenic pain and left ventricular hypertrophy and renal impairment. In UK, enzyme replacement therapy is now started following a diagnosis in symptomatic patients. Now, we are going to discuss the second category of inherited metabolic disorders, that is the mitochondrial respiratory chain disorders. Mitochondria are responsible for production of adenosine triphosphate, ATP, using energy released during the oxidation. The mitochondrial disorders can affect any tissue, but the neuromuscular problems are the commonest. But as the disease progresses, increased number of apparently unrelated organs are involved. These disorders have varied pattern of inheritance. In addition to the usual pattern, the mitochondria also have their own genome, which are called as the mitochondrial DNA, which is inherited exclusively from the mothers. These mitochondrial DNA mutations can be homoplasmic, that affects all the copies in the cell, or heteroplasmic, affect a portion of copies. Symptoms are more severe if level of mutation in mitochondrial DNA is high, or they are homoplasmic. Dermatological features of mitochondrial disorders: multiple symmetric lipomatosis. There are multiple lipomas symmetrically distributed over back, neck, and shoulder, often recurring after removal. The classic combination of myoclonus epilepsy and myopathy. Other features include deafness, ataxia, and childhood neurodegenerative disorder, which are called as the leak syndrome. Another feature of mitochondrial storage disorders is the acrocynosis. There is orthostatic acrocynosis. Patients have intermittent red or purple discoloration of feet, but hands is plus minus, without trophic changes. Other systemic problems are diarrhea and developmental delay, and treatment is with N-acetylcysteine and metronidazole. Then the third feature is palmoplantar keratoderma, which is of non-epidermolytic type, and all affected individuals also have a sensorineural hearing loss. Sole of feet are involved earlier and more frequent than palms. Then other dermatological features include hypertrichosis, particularly in leak syndrome, erythema, ichthyosis, pruritus, reticular hyperpigmentation, and poikiloderma. So the main dermatological findings in mitochondrial storage disorders are multiple lipomatosis, which is itself a distinct syndrome, that is leak syndrome. Then acrocynosis, palmoplantar keratoderma, hypertrichosis. Then the third category of diseases we are discussing among the metabolic inborn errors of metabolism are the congenital disorder of glycosylation. These are also named as the carbohydrate deficient glycoprotein syndromes. The congenital disorders of glycosylation are multisystem disorders caused by defect in glycosylation of proteins or lipid and inherited as autosomal recessive. Patients mainly have neurological involvement and many dermatological features. The prominent one include pudgy orange appearance of the skin, inverted nipples, and fat pads, cutis laxa, hypohidrosis, hypopigmented macules, reticular hyperpigmentation, and tumoral calcinosis are other dermatological features in congenital disorder of glycosylation. Among this heading, we are going to discuss two other diseases. The first is the phosphomonomutase 2 deficiency. Patient present as newborn with hypotonia, internal strabismus, psychomotor retardation, inability to walk, feeding problems, and poor growth. Some have subcutaneous pads over the iliac crest with lipodystrophy of rest of the buttocks. Nipples are often inverted, and there is hepatomegaly and hypogonadism. Skin may have loose folds and feel thick or pudgy orange, so either cutis laxa appearance or pudgy orange appearance. The dysmorphophobic features include large dysplastic ears, skeletal abnormalities such as long fingers and toes. Complications include stroke-like episodes, epilepsy, retinitis pigmentosa, severe infection, renal or hepatic impairment, cardiomyopathy, and pericardial effusion. There is high mortality 20% in first few years, but subsequently mortality is much lower and neurological regression is rare. Most congenital disorders of glycosylation are diagnosed by transferrin isoelectric focusing. Management. Unfortunately, there is no effective treatment for these disorders. Then comes the fourth category of disorders of amino acid metabolism and transport. These disorders, these category include some very important metabolic disorders. The disorders of amino acid metabolisms are autosomal recessive, multisystem, and problems are resulting from deficiency of amino acids, or from toxic accumulation of an amino acid or related chemical. Neurological problems are common in these disorders and which may be acute, present as encephalopathy or coma, or chronic, present as psychomotor retardation. These disorders are usually diagnosed by analysis of amino acids in plasma or urine, or organic acids in urine. Most of these patients are treated by special diets. The amino acid disorders with dermatological features include Phenylketonuria. The prominent feature to be remembered in Phenylketonuria is the hyperpigmentation of the skin, hair, and eczema. Then Tyrosinemia type 2. Important skin finding is the painful palmoplantar hyperkeratosis. Alkaptone Urea. There is pigmentation of pinna, sclera, skin, and buccal mucosae. Hartnup disease. Photosensitive disorders like pellagra. Homocystinuria, characterized by pale skin and hairs, ulcers. Livedo reticularis on the legs. So now we are going to discuss these diseases one by one. The first one is the phenylketonuria. Phenylketonuria is due to the defect in phenylalanine hydroxylase, the enzyme that catalyzes the conversion of phenylalanine to tyrosine, that result in accumulation of phenylalanine in the body. Since the enzyme that is important in conversion of phenylalanine to tyrosine is defective, so the phenylalanine accumulate in the body, and the disorders are known as the phenylketonurias. In most developed countries, phenylketonuria is detected by newborn screening, and the classical clinical features are seldom seen. Patient presents during infancy or early childhood with psychomotor retardation, behavior problems, and seizures. The untreated patients have increased incidence of eczema, 20 to 40%, reduced pigmentation of hair, skin, and iris, and the altered pigmentation is caused by impaired synthesis of melanin and improves with tyrosine supplementation. So this is one of the patient, Marha, that is diagnosed with phenylketonuria, and you can see the light color hairs and iris in such patient. Investigation is by plasma amino acid analysis. Management, restriction of dietary phenylalanine. Most patients require a semi-synthetic diet, which is extremely low in the natural proteins, with a supplement containing all the amino acids except phenylalanine. The diet also corrects the tyrosine deficiency, so treated patients have normal pigmentation. Many adults revert to the normal diet without major problems, though there is a risk of nutritional deficiencies. Second of the amino acid disorder is the Tyrosinemia type 2. It is caused by deficiency of tyrosine aminotransferase, which catalyze the first step in tyrosine degradation. The disease is characterized by corneal ulcers seen in 75% of the patient, And the second important feature is the painful palmoplantar hyperkeratosis that is seen in 80% of the patients. And such patients have the learning difficulties, which is seen in almost 60% of the patients. The ophthalmic problems arise because of the tyrosine crystals that are precipitating in corneal epithelial cells. Such patients present with photophobia and ear pain, often during the first year. The slit lamp examinations show dendritic corneal erosions resembling herpetic ulcers. Without treatment, the corneal scarring may lead to permanent visual loss and glaucoma. The typical skin problem appear after first year, and these are the painful hyperkeratotic plaques that appear on palm and soles, including the digits, mainly found on the pressure points such as the fingertips. There may be hyperhidrosis and leukokeratosis of the tongue. Some patients have poor fine coordination, severe cognitive impairment, and difficult and aggressive behavior. Some patients are also mentally retarded, but with no skin or eye problem. These are the few common typical symptoms in Tyrosinemia type 2. The ocular symptoms include corneal opacities and corneal ulcers. There are painful palmar hyperkeratosis and plantar hyperkeratosis with hyperhidrosis. Investigation: amino acid analysis show marked increased plasma tyrosine concentration above 1200 micromole per liter. It is also confirmed by mutation analysis. Treatment is mainly dietary. A low protein diet leads to acceptable tyrosine concentration. Other needs a more specific protein restriction and amino acid supplement free of tyrosine and phenylalanine. Eye and skin problems resolve if plasma tyrosine concentration is kept below 800 micromole per liter, but for treating the neurological problem, the target level of tyrosine level should be below 500 micromole per liter. The third disorder we are going to discuss here is the Alkaptonuria. Alkaptonuria is a very rare inherited disorder that is caused by homogenistate dioxygenase deficiency that leads to accumulation of homogenistic acid. This can be polymerized to form dark pigment, which is deposited in the connective tissues. These patients mostly have low back pain of early onset, that is 25 and 40 years, with progression to kyphosis and ankylosis. Other patients present with arthritis of hip or knee. Many patients require joint replacement and some become bedridden. Older patients often develop calcification of aortic or mitral valves or the corneal arteries. Children are asymptomatic, but their urine darkens after a few hours, particularly if it is alkalinized. So the cloth nappies are therefore turned black when washed, and this is mainly a clue for the diagnosis of Alkaptonuria. These are the few symptoms of Alkaptonuria. The first is the black colored urine if kept for some time. Acrodermatitis is the bluish gray pigmentation of the face. Tendinitis, kidney and prostate stone, and kyphosis or hunchback. Acrodermatitis. Acrodermatitis is a melanin-like black pigmentation which is seen from any age 30 years onward. The cartilage of ears develop gray or blue-black discoloration and feels thick and inflexible. The cerumen may be brown or black. Brown or gray deposits also appear on the sclera. Pigmentation is also seen in the buccal mucosa, and nails are also brown. There may be dusky discoloration of skin, especially over the cheeks, forehead, axillae, and the genital regions. You can see the progressive increased pigmentation we see in the sclera as well as on the ear cartilage as the patient ages. The diagnosis is established by urine organic acid analysis to reveal the homogenistic acid in the urine. Management: no treatment has been shown to prevent the long-term complications. Nitisinone inhibits the first step in tyrosine breakdown, and even at low doses, it reduces plasma and urine homogenistic acid by 95%. But studies showed no difference in progression of joint disease, possibly because arthropathy was already too advanced before the treatment. The fourth disorder we are going to discuss among the heading of amino acid disorders is the Prolidase deficiency. The Prolidase deficiency is caused by the inability to break down imidodipeptides. It is uncertain how the accumulation of imidodipeptides cause the clinical problems. Patients present at any time from birth till 22 years. There are recurrent ulcers on the leg. The ulcers are resistant to treatment and complicated by secondary infection. Other skin problems include dermatitis, fine scarring, telangiectasias, purpura, and bruising. There may be lymphedema or a doughy consistency of the skin. Many patients have psychomotor retardation, and some have characteristic facial appearance with hypertelorism and shallow nasal bridge. Systemic features include the chronic lung disease resembling systemic fibrosis, splenomegaly, anemia, thrombocytopenia, hypergammaglobulinemia, and increased risk of developing SLE. Multiple ulcers with unusual distribution on the legs prompts the physician to diagnose Prolidase deficiencies. But these ulcers are characterized by scarring and surrounding purpura and ecchymosis. Investigation: plasma or urine amino acid analysis show various imidodipeptides. The diagnosis is now confirmed by mutation analysis. Management: no specific treatment is known to help, although there have been anecdotal reports of success with various agents that include ointment containing glycine and proline, systemic ascorbic acid or manganese, the core factor for Prolidase. Skin grafts are unsuccessful and infections should be treated aggressively. Fifth disorder we are going to discuss here is the arginosuccinic aciduria. It is a rare urea cycle disorder, present acutely with hyperammonemia and chronically with learning difficulties and trichorexis nodosa. Many patients present with vomiting, confusion, and coma due to acute hyperammonemia and often occur 12 to 72 hours after birth, although it can happen at any age. Patient with some enzyme activity often presents at few years of age with learning difficulties and thinning of hairs, which are dry and brittle. Even with treatment, most patients with severe defect develop neurological problems, epilepsy, and chronic liver disease. Arginosuccinic acid is best detected by urine amino acid analysis, although it is also present in the plasma. Treatment involved dietary protein restriction. The drugs include sodium benzoate or sodium phenyl butyrate One arginine is also given to facilitate the excretion of ammonia. These measures prevent hyperammonemia and lead to resolution of trichorexis nodosa. Then the disease we are going to discuss among the amino acid metabolism disorders is the Hartnup disease. The Hartnup disease is because of nicotinamide that is essential for many reactions and can be formed from tryptophan or from tryptophan. In patients with Hartnup disease, there is an impaired intestinal absorption of tryptophan, which is a neutral amino acid that leads to reduced synthesis of nicotinamide. Such patients present with pellagra-like rash and neurological problems. Patients present with a rash at 3 to 9 years of age. The rash is well demarcated dry scaly patches on sun-exposed skin such as face, back of hands, and exposed parts of the arms. Exposure to sunlight causes erythema, sometimes with blistering, that is followed by desquamation and depigmentation. This is the typical pellagra-like rash which we see in patients of Hartnup disease. Cerebellar ataxia is the commonest neurological problem that usually starts after the rash sets in, and it presents as nystagmus, tremors, weakness, or psychiatric problems. Symptoms tend to improve with age even without treatment. Investigation, there is increased neutral amino acids in urine and low normal concentration in plasma. Management, the rash and neurological problem generally resolve with oral nicotinamide 50 to 300 milligram per day, and a high protein diet is recommended. Then we come to the fourth of the metabolic disorders, inborn errors of metabolism, that is the disorder of cholesterol synthesis. There are a number of inborn errors affecting the cholesterol synthesis, and two of these cause dermatological problems that include ichthysis. Some other disorders of cholesterol synthesis include sterol isomerase deficiency, chondrodysplasia punctata, Conradi-Hunterman syndrome, and child syndrome. We are not going to discuss these disorders here, but we are going to discuss two disorders here, that is Smith-Lemli-Optis syndrome and mevalonate kinase deficiency. The Smith-Lemli-Optis syndrome results from 7-dehydrocholesterol reductase deficiency and is the commonest of disorders of cholesterol synthesis with wide range of severity. Such patients have facial dysmorphism, syndactyly of toes, undescended testes, failure to thrive, microcephaly, mental retardation, and autism. Main dermatological problems are photosensitivity, hypopigmented hair, hyperhidrosis, eczema, and acrocyanosis. Diagnosis is made by demonstrating elevated plasma 7-dehydrocholesterol level. Treatment with cholesterol does not alter the cognitive outcome but improve the photosensitivity. The mevalonate kinase deficiency is mildly affected patients. Only problems are episodes of fever and inflammation every 4 to 6 weeks with high level of IgD. During these episodes, there is erythematous maculopapular rashes with lymphadenopathy, arthralgias, and abdominal pain. The severely affected patients have dysmorphism, failure to thrive, mental retardation in addition to the episodes of inflammation. Diagnosis is made by demonstrating mevalonic acid on urine organic acid analysis, and there is no specific treatment. Then we have reached to the end of our talk, and in the end we are going to discuss a few very important metabolic disorders which cannot be categorized in the above categories, but we will discuss it under this heading of miscellaneous or other metabolic disorders. The first of these is the Lesch Nyhan syndrome. The Lesch Nyhan syndrome is an X-linked disorder that is caused by hypoxanthine guanine phosphoribosyl transferase deficiency. It is characterized by neurological and psychological problems with compulsive self-mutilation and complicated by hyperuricemia. Patient present after 4 months of age with delayed motor milestones, followed by chorea, spasticity, and dysarthria. Subsequently, they develop a compulsion to injure themselves, although they have normal pain sensations. Biting leads to self-amputation of fingers and parts of the lips. They are aggressive to other people, both physically and verbally. IQ is high, usually 60 to 70. The IQ is around 60 to 70, and many patients have seizures. Self-mutilation of fingers and of lips is a feature of Lesch Nyhan syndrome. Without treatment, patient develop renal uric acid stones, but gouty arthritis is uncommon. Uric acid excretion is increased as the plasma urate concentration in most patients. The diagnosis is confirmed by measuring HPRT activity in the erythrocytes. Management: allopurinol is given to prevent the urate nephropathy, but it does not affect the neurological problems for which there is only symptomatic treatment. Self-mutilation can be reduced by restraints such as elbow splints and lip guards or extraction of the teeth. Disorders of biotin metabolism. Biotin is a water-soluble vitamin and is a cofactor for 4 carboxylase reactions involved in amino acid degradation, in gluconeogenesis, and fatty acid synthesis. So biotin has a wide role. And deficiency of either biotinidase or holocarboxylase synthetase lead to multiple carboxylase deficiency. The clinical features of biotin deficiency include acidosis, seizures, leading to coma and death. Patient with some residual enzyme activity may present with developmental impairment and hair loss or rashes. Rashes are widespread, erythematous and scaly, and particularly affecting the napkin, and the rashes resemble ichthyosis or seborrheic dermatitis. Hairs are sparse, and some patients have complete alopecia, including loss of eyebrows and eyelashes. So biotin deficiency leads to hair loss even in adults. The biotinidase deficiency is diagnosed by newborn screening in some countries and confirmed by mutation analysis. Such patients are treated with biotin 5 to 10 milligrams per day. Unless treatment is started early, the cognitive, hearing, and visual problems are likely to persist. Few patients only show partial response and may have learning difficulties despite early treatment. Another important inborn metabolic disorders is Acrodermatitis Enteropathica, which is both inherited and acquired. But here we are going to discuss the inherited form of Acrodermatitis Enteropathica is an autosomal recessive disorder affecting the intestinal absorption of zinc. The resulting zinc deficiency leads to dermatitis, alopecia, and diarrhea. Symptoms start after weaning in breastfed babies and at 4 to 10 weeks in bottle fed. Patient present with apathy or irritability and a rash around mouth and anus and on hands and feet. The erythema progressed to vesicle, bully, pustules, and desquamation and crusting. There is alopecia and frequently blepharitis, conjunctivitis, and photophobia. Infections are common that include secondary infection with Candida albicans and poor wound healing. Many patients have diarrhea and growth failures. Without treatment, condition can be fatal. So acrodermatitis usually patient present as perioral and periorificial dermatitis or rash with involvement of digits and palm and soles. The differentials include biotinidase deficiency, which present as rash similar to Acrodermatitis Enteropathica, and protein malnutrition. Investigation: serum zinc level is usually low, and it is easier to undertake a trial of zinc therapy as patients respond very quickly within a week. So even if zinc level is not available in the laboratory, we can give a trial of zinc therapy. Management: oral zinc sulfate in a dose of 150 to 400 milligram per day is started in childhood, while the lower dose is needed after puberty. But during pregnancy, the dose is to be increased to 400 to 500 milligram per day. And this zinc sulfate supplement is to be continued throughout the life. If zinc sulfate causes gastric problem, other zinc salt or encapsulated preparations are recommended. Monitoring for copper deficiency should be undertaken. So the next important disease we are going to discuss is the Menkes disease and the occipital horn syndrome. Menkes disease is a rare X-linked disorder in which copper deficiency leads to neurodegeneration, kinky hairs, and connective tissue abnormalities. The occipital horn syndrome is a rare allelic variant with connective tissue abnormalities but no neurodegeneration. The Menkes disease is caused by mutation of ATP7A, encoding a transporter for copper. This defect prevents the transport of copper from intestinal mucosa to portal circulation and leads to copper deficiency. The neurological problems can be explained by role of copper in mitochondrial functions and neurotransmitter synthesis. Boys with Menkes disease present at 2 to 3 months with hypotonia and seizures, and later with developmental regression and spasticity. Hair soon becomes sparse and brittle. Microscopic examination show polytorti and occasionally trichorexis nodosa. Patients acquire a characteristic facial appearance with sagging cheeks and frontal bossing. Skin is loose, especially on back of neck. Untreated patients gradually die by 3 years of age. Hypotonia and decreased muscle tone is one of the important features of Menkes syndrome. Then the second important feature is brittle and sparse hairs, which is because of polytorti and trichorexis nodosa. The clinical variant is occipital horn syndrome, which is a mild variant in which demineralization, exostosis, especially over the occiput, is seen. Skin and joints are lax, and disorder was previously called as the X-linked cutis laxa. Investigation of the Menkes syndrome is low serum copper and ceruloplasmin concentration, which is diagnosed after 3 months of age. Management is done by daily subcutaneous injection of copper histidine. That improves the outcome, but only if started within a month of birth. Copper histidine injection do not correct the connective tissue abnormalities. The next important disease to be discussed is the Wilson's disease. The Wilson disease is copper accumulation that leads to hepatic or neuropsychiatric problem, and dermatological features are mild. So the Menkes disease was because of copper deficiency, and Wilson's disease is because of copper accumulation. Patients present as children or young adults. There is deficiency of copper transport ATPase, reducing the excretion of copper in bile and its incorporation into ceruloplasmin. Copper accumulates in liver and subsequently in brain, kidney, and other tissues. They present acutely with hepatitis and liver failure, or incidentally as cirrhosis. The neurological manifestation develop at 12 and 30 years with dysarthria, deteriorating handwriting, tremors, dystonias, and drooling of saliva. Some patients present with behavioral changes or psychosis. A classical Kaiser-Fleischer rings may be seen at the limbus of the cornea, particularly in patients with neurological symptoms. This is the spasticity of dystonias, and this is a typical Kaiser-Fleischer ring, which is a brown ring that is seen at the limbus. Dermatological features are mild and not troublesome. Blue lanula of the nails are the most specific findings, but not very common. In addition, there is xeroderma and gray-brown hyperpigmentation on extensor surfaces of leg and cheilitis. Investigation: serum copper and ceruloplasmin concentration are generally low with raised 24 hours urinary copper excretion and raised liver copper. Management: treatment promotes copper excretion, which include the chelators, that is penicillamine, the trinitine, and tetrathiomyl or zinc, which increase the fecal excretion of copper that is bound to melatonin. Penicillamine is recommended in patients with liver disease, but most recur, but a few require liver transplantation. Most recover, but few require liver transplantation. Unfortunately, neurological problems seldom resolve completely. And indeed, there is often an initial deterioration on treatment. Then the last of the miscellaneous metabolic disorder we are going to discuss is the familial tumoral calcinosis. Ectopic calcification in skin is termed as cutaneous calcinosis or calcinosis cutis. Acquired ectopic calcification in skin is classified into the metastatic and dystrophic. In metastatic calcium deposits results from elevated blood level of calcium and or phosphate. While in dystrophic calcinosis, the calcified material accumulate following some form of primary tissue damage. The hereditary counterpart of acquired metastatic calcification is hyperphosphatemic familial tumor calcinosis, HFTC. The disease manifests with formation of large calcified masses located mainly over the large joints. They cause pain and can become secondarily infected. Calcification can also involve visceral organ and teeth. You can see the calcified masses and also seen calcification within the visceral organs. In this histopathology, you can see the bluish, irregular shaped deposits within the dermis. The inherited equivalent of dystrophic calcification is termed as the normophosphatemic familial tumor calcinosis, NFTC. Patients affected shows calcified lesions that are smaller and superficially located and therefore perforate the skin, leading to painful ulcers and secondary infection. The calcinosis cutis can occur in other genodermatoses such as Albright, hereditary osteodystrophy, Rothman-Thompson, hereditary sclerosing poikiloderma, and pseudoxanthoma elasticum. Management is generally by surgical removal of calcified masses when there is significant functional impairment with unacceptable cosmetic appearance. Treatment with phosphate binders is mostly disappointing in patients with hyperphosphatemic familial tumoral calcinosis, but acetazolamide may be of some benefit. So I thank you so much for listening. I know it was a difficult topic, but I hope I have done some justice to the topic. Thank you very much again, and See you next time with another edition of my lectures. Goodbye and have a good day.